Hyperpigmentation. Letter of referral. Dear Dr. Re. Miss Helen Potter, aged 24 years. Please could you see this young woman who has noticed increasing pigmentation on her forehead and beneath her eyes for the past 2 years. It is worse in the summer months and is increasingly a cosmetic problem to her. Yours sincerely. Introduction. Hyperpigmentation of the skin is a common problem of varied etiology. It is useful to divide the causes into localized areas of hyperpigmentation, which are normally harmless, and generalized hyperpigmentation, which may indicate an underlying systemic disease. Causes of localized hyperpigmentation. Freckles, ephyllodes. Small pigmented macules, 3 mm, on sun-exposed sites. If there are many or odd freckles associated with photosensitivity and skin tumors, think of xeroderma pigmentosum. Café au lait macules. Consider neurofibromatosis. Chloasma. Patchy symmetrical facial pigmentation on sun-exposed skin. Occurs particularly on the forehead, cheeks, and upper lip, and in females. Acanthosis nigricans. Velvety thickened skin, particularly in flexures. Patient may be obese or have an underlying malignancy. Post-inflammatory hyperpigmentation. At sites of previous inflammation, e.g. eczema or lichen planus. Look for the remains of the preceding rash. Commoner in racially pigmented skin. Fixed drug eruptions leave circular areas of pigmentation which become inflamed intermittently at the same site on re-exposure to the causative drug. Hemosiderosis. Red or brown, often speckled, pigment on lower legs in patients with venous hypertension. Drugs. For example, minocycline, blue or black and symmetrical pigmentation, amiodarone and chlorpromazine, both produce blue or slate gray color on exposed sites, e.g. nose. Porphyria cutanea tarda. Diffuse tanned appearance on sun-exposed sites. Pityriasis versicolor. Cause of truncal dappled hyperpigmentation and or hypopigmentation. Fine scale. Alkaptonuria. Blue or gray pigment is generalized, but often noticed on ears and nasal tip. Causes of generalized hyperpigmentation. Addison's disease. Diffuse pigmentation, localized particularly in palmar creases and buccal mucosa. Ectopic ACTH/MSH. Consider small cell lung cancer. Acromegaly, hyperthyroidism, and pheochromocytoma. Occasionally cause Addison's type hyperpigmentation. Malabsorption, malnutrition, and cachexia. Diffuse brown/gray pigmentation. Chronic renal failure. Diffuse brown/yellow pigmentation. Systemic sclerosis. Diffuse brown/gray pigmentation. Hemochromatosis, bronzed diabetes. Gray/bronzed skin. Hyperbilirubinemia. Yellow pigmentation, particularly sclera. Hepatic cirrhosis. Particularly primary biliary cirrhosis, brown pigmentation. Drugs. For example, busulfan, bleomycin, and cyclophosphamide, brown pigmentation, mepacrine, yellow pigmentation. Carotenemia. Generalized yellow/orange color, particularly on the palms. Pigmentary changes are often due to an increase in melanin within the skin, but other substances such as bilirubin and drug metabolites can cause hyperpigmentation when present in excess. History of the presenting problem. Where is the hyperpigmentation? The distribution is vital to the diagnosis. Localization on sun-exposed sites may indicate the common diagnosis of chloasma or a drug etiology such as amiodarone. Acanthosis nigricans is usually confined to flexural sites. Addison's disease causes diffuse hyperpigmentation but may only have been noticed by the patient in the palmar creases or in the mouth. When did the hyperpigmentation occur? Most causes are acquired, but caféola macules and neurofibromatosis may have been present since childhood. Onset in the summer months or when pregnant is classical of chloasma. Is it made worse by sunlight? Freckles, ephyllodes, are normal on sun-exposed skin in summer months. Multiple odd freckles, a history of photosensitivity, early photoaging and/or skin cancers at a young age raises the possible diagnosis of xeroderma pigmentosum. Chloasma and some drug rashes are exacerbated by sunlight. Has the skin always looked like this, or was there a different appearance before? Many inflammatory rashes such as lichen planus or eczema may be extremely itchy and inflamed before settling and leaving post-inflammatory hyperpigmentation. Fixed drug eruptions are localized areas that become repeatedly inflamed and may blister, following ingestion of a drug, before settling to leave pigmentation in the skin. Other relevant history. Drug history. This is vital. Drugs can cause both localized and generalized pigment changes. Many drugs, commonly NSAIDs, can cause fixed drug eruptions. Minocycline causes localized blue/black pigmentation after long-term use. Mepacrine can cause a diffuse yellow pigmentation in the skin. General health. This is most important in cases of generalized hyperpigmentation. Is there anything to suggest endocrine problems such as Addison's disease, acromegaly, hyperthyroidism, or pheochromocytoma? Small cell lung cancers can secrete ACTH and give similar Addison-like hyperpigmentation. Chronic renal failure, liver failure, and generalized malnutrition and malabsorptive conditions can all be associated with diffuse brown or gray pigmentation. Diabetes is associated with both acanthosis nigricans, localized, and hemochromatosis, diffuse pigmentation. Hyperpigmentation examination. General features. Bearing in mind the possible causes, particularly generalized hyperpigmentation which may be associated with an underlying systemic disease, take time to survey the patient. Is she jaundiced or cachectic? Is there a dialysis fistula in the forearm or a peritoneal dialysis catheter? Does she have the mask-like facies of systemic sclerosis? Cutaneous examination. Key points to look for include the following. Facial skin. What is the distribution of the pigmentation problem? Freckles and chloasma are usually symmetrical and present at sites of maximum sun exposure, i.e. cheeks, chin, and upper lip. The pinny and nasal tip may be discolored in achronosis. Are there any signs of systemic sclerosis? In porphyria cutanea tarda, there may be hypertrichosis in addition to diffuse hyperpigmentation of sun-exposed sites. Eyes and sclera. Look for the presence of jaundice. Carotenemia is associated with normal sclera. Oral mucosa. Is there any pigmentation of the lips/oral mucosa? If so, consider Addison's or Peutz-Jeghers syndrome. Rare malignant forms of acanthosis nigricans can also affect the lips. Nails. Look for signs of an inflammatory skin disease, e.g. psoriasis, pitting, onycholysis and subungual hyperkeratosis, or features of other skin problems, e.g. tracheonychia, sand-blasted nails, or pterygium, scarring of nail plate, in lichen planus. Any inflammatory skin condition, in particular lichen planus, could leave post-inflammatory hyperpigmentatio. Look for pigmentation changes of the nails, which can be caused by drugs. Hands. Look for pigment in the palmar creases, classical sign of Addison's disease, and orange discoloration of the palms, carotenemia. Is there freckling/discoloration of the dorsum of the hands, i.e. sun-exposed skin? Freckling may be severe and photoaging advanced in xeroderma pigmentosum. Drugs such as amiodarone and gold particularly cause discoloration at exposed sites. Hemochromatosis also causes pigmentation of exposed skin. Look for signs of systemic sclerosis, e.g. sclerodactyly, digital ulcers, tight skin and telangiectasies. Examination of trunk and limbs. What is the distribution of the pigmentation? Acanthosis nigricans particularly affects flexural sites. Addison's disease, chronic renal failure, liver disease, and malnutrition may cause diffuse hyperpigmentation. Is the rash scaly? Pityriasis versicolor may cause dappled hyperpigmentation on the trunk that is scaly on close inspection. Is the skin texture normal? Thickening of the skin may occur with post-inflammatory hyperpigmentation, usually secondary to rubbing of the skin, causing lichenification. Systemic sclerosis causes thickening of the dermis and change in skin texture. Examination of other systems may be appropriate, e.g. abdominal examination in suspected hemochromatosis. Further discussion. Excess pigment is usually due to melanin in the skin, produced by melanocytes, as in freckles induced by sunlight. Post-inflammatory pigment is also usually melanin, released from melanocytes in the basal layer following inflammation and damage. Other substances can cause pigment changes, such as excess bilirubin causing jaundice or drug metabolites, e.g. minocycline. Plan for investigation and management. A full cutaneous examination is required to determine the distribution and nature of the abnormal pigmentation. Perform a full systemic examination if a systemic cause is suspected. Investigations. Blood tests, FBC, renal function, liver function, glucose, thyroid function tests and ferritin. Abnormal electrolytes, low sodium, high potassium, are expected in Addison's disease. Perform a full endocrine workup depending on the suspected diagnosis. CXR, if there is diffuse hyperpigmentation, to look for possible small cell lung carcinoma. Skin scrapings, to look for yeast spores and hyphae if pityriasis versicolor is suspected. Management. Management will clearly depend on the underlying diagnosis. Cloasma. Reduce sun exposure with avoidance of the sun and the daily use of a high-factor sunblock. Suggest stopping the oral contraceptive pill if this is thought to be the cause, remembering to remind the patient to use an alternative method of contraception and also of the fact that pregnancy will exacerbate cloasma. Cosmetic camouflage can be used. Topical skin bleaches, such as hydroquinone, can help, but should be used with care due to the risk of achronosis. Pityriasis versicolor, topical azoles or oral antifungal agents such as itraconazole in widespread cases. Post-inflammatory hyperpigmentation, there is no treatment other than reassurance that it should gradually fade with time. Systemic causes, treat underlying disease. Further discussion. What is the most likely diagnosis? In this case, with facial hyperpigmentation that gets worse in summer, cloasma is most likely. In an older patient, consider a drug such as amiodarone or chlorpromazine as the cause.